My name is James Mason. I'm a health economist working for Warwick University Medical School. This is a brief talk about the economic analysis of the stopgap trial, which compared two oral drug treatments, cyclosporin and prednisolone, for patients with pyoderma gangrenosum. The analysis, by looking at cost and quality of life, provides additional and partially discordant findings when compared with those reported by the clinical trial. Pyoderma gangrenosum is an uncommon, progressive, painful, ulcerating skin disease. However, we are currently unsure which treatments work best because of a lack of good evidence. Topical treatments include potent supersteroids and calcineurin inhibitors such as tacrolimus, and commonly prescribed systemic treatments include oral steroids and immunosuppressants such as cyclosporin. Oral prednisolone has been the main systemic treatment for more severe pyoderma gangrenosum for many years, but some clinicians prefer cyclosporin, believing it to be more effective with fewer side effects. Given the lack of evidence, the stopgap trial was designed to test whether treatment with cyclosporin was superior to prednisolone. This multi-centre randomised controlled trial of 112 patients found a similar rate of ulcer healing at 6 weeks and similar numbers of ulcers healed after 6 months of treatment. Having found no difference for a range of clinical and patient-reported outcomes, the trial concluded that treatment decisions for individual patients should be guided by the different side effect profiles of the two drugs and patient preference. Economic analysis is a further and complementary way of comparing treatments, setting the overall costs of each treatment against changes of patient quality of life. Costs include the treatments themselves and also other health resources that are used, such as hospital and primary care visits. These may be due to ulcer care, but also complications of treatment. Health-related quality of life captures changes in patients' health over time as their ulcers heal or complications occur. At the most simple level, each patient's health at any point in time can be thought to vary between full health, worth 1, and death, worth 0, with some health states potentially worse than death, having negative scores. Health economists value these changes in health over time using the QALY, or Quality Adjusted Life Year. 1 year in full health is worth 1 QALY. The stopgap trial recorded the difference in QALYs between the two treatments, with each patient followed up for up to 6 months and assuming no subsequent difference in treatments. At first glance, the economic analysis findings differ from the clinical findings. In an analysis including all trial patients, cyclosporin was more cost-effective than prednisolone, since it reduced costs by nearly £1,200 on average per patient and modestly improved quality of life. These estimates are uncertain for a range of reasons. The uncertainty is reflected in a confidence region around the estimate of cost-effectiveness. However, the overall finding was driven by a minority of about a third of patients who started the trial with large ulcers. In patients with large ulcers, cost savings and quality of life gains were even more marked, being partly due to greater levels of hospitalisation for complications while receiving prednisolone. In the majority of patients starting the trial with smaller lesions, costs were similar. Quality of life gains still favoured cyclosporin, although these were small in magnitude. Consistent with the clinical findings of the stopgap trial, patients with small lesions should receive treatment guided by the side effect profiles of the drugs and patient preference. Neither strategy is clearly a preferred use of NHS resources. However, cyclosporin-initiated treatment may be more cost-effective for patients with larger lesions. Full details of this economic analysis are found in the British Journal of Dermatology publication.